Good morning, everyone, and happy Hump Day. This is Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Telehealth in the Midst of COVID-19. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Bear with me a few minutes while we go through some housekeeping slides, and then we will get started on our presentation. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me by using the Q&A panel or the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions at the end of the presentation, and we will also be keeping a log of those questions that we don't get to today to answer at another time. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 days. One helpful hint is the archived video displays what looks like to be an error message, but it's only a delay buffer, so you can just ignore it and hit play and enjoy. To access the recording and PowerPoint, go to www.fada.org, Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note the evaluation will close at midnight on Friday, April the 10th. 1 or 2 continuing education credits are available for participating in today's webinars for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage, Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenter today. Dr. Mark Stavros is a clinical associate professor at the Florida State University College of Medicine, Emergency Medicine. Dr. Stavros is the Emergency Department Medical Director at the West Florida Regional Hospital in Pensacola, an assistant clinical professor at the Alabama College of Osteopathic Medicine, He is a fellow of the American Board of Emergency Medicine and the American Board of Addiction Medicine. As an expert in addiction medicine and treatment of opioid use disorder, Dr. Stavros is involved in various community organizations. He consults with the media and educates medical and judicial professionals about the need for compassionate therapeutic care and the necessity of reducing the stigma associated with substance use disorders. And now I would like to introduce Dr. Stavros. We have special thanks to you for showing up today. We know that this is a difficult and trying time, and so we give special thanks to you.
Well, thank you for having me, and I'm happy to be here. I'm actually calling in from my home, so I am away from any patients right now as well, so it's kind of an interesting time. So, and obviously the ER is a very exciting place too. Today I really want to talk about telehealth in the midst of the COVID-19 crisis. There's been a lot of changes. I'm going to do a brief overview about telemedicine, telehealth, and some of the benefits from that, and some of the legislative changes that have been occurring. This is a very fluid type of situation, just like the COVID-19 has been a fluid situation, trying to figure out exactly what we need to do and not do. Same with telemedicine. There's legislation that's literally changing probably as we speak, so we'll go through some of that as well. And I am not able to move that slide, so.
Okay, you want to try it now, Dr. Stavros?
Keep on going here. I don't have anything to disclose for what that's worth. I still have no control to move it, though.
Okay.
You may click on the slide itself and then try and move it. There you go.
There we go. All right. So some of the benefits, obviously, of telehealth, and from a provider standpoint, it allows remote monitoring. And by what we mean by that is, you can monitor vital signs or blood sugar or weights of patients. Somebody could be at their house and can call in or actually have a telecommunication of various aspects of their health care. This expands access to care, obviously, for the providers as well. You can be in more than one place at one time, which is pretty amazing. So instead of having to travel everywhere, you can literally virtually travel very quickly as well. This obviously reaches more patients. It really increases your bandwidth as a provider, and you can treat a lot more patients that way. We can really start to be more efficient, improve our clinical workflows and our efficiency as well. And then, overall, we don't have to have separate offices every single place we go, so that ultimately could reduce overhead and maybe even have less staff as well. From the patient standpoint, again, this is hugely beneficial depending on how you're using telemedicine, but in a lot of cases, patients don't have to transport, right? So they don't have the time to do the transportation or the cost for transportation. And that's very impactful, not only in the United States, but also internationally. I've had an opportunity to do telemedicine on an international aspect, and I'm in the rural mountains of Panama where these patients don't have access to care, or if they're going to get care, it is profoundly expensive, maybe a month's salary just to get to a local hospital. Whereas if you brought in telemedicine equipment, you can do evaluations and be able to do that remotely, which can be pretty impressive. There's no need to take time off work for patients. They could literally do this from the comfort of their home, or even if they are at work, instead of having to leave work for half the day to go to an appointment, they could literally take 15 or 30 minutes off on a break and be able to see a medical provider of some sort. Obviously, it eliminates the need to extend extended child care or elder care. There's a lot of stuff that goes behind the scenes of just making an appointment with a doctor and having to take that time and go to a clinic. Obviously, a lot of time is spent in a waiting room, and then in this situation, you have a lot less time in a waiting room situation, and this improves the access to care for patients as well. So in the light of COVID-19, obviously, we are trying our best to do social distancing. We don't want patients, we don't want anybody pretty much next to each other at this point. And so this is really promoting an opportunity where we can provide social distancing. And so, we're shifting those visits from inpatient, face-to-face interactions that require in-person visits to situations where patients are more separated. And right now, there's nobody that's going to catch anything from me if I had any type of virus. And so that's fantastic. And we have that medium that is preventing that physical contact and the spreading as well between patients and staff as well. It reduces, obviously, the risk of spread in high volume traffic areas. So obviously waiting rooms are a high volume area, and this reduces the number of patients that have to require face-to-face visits. And the government really has taken pretty profound steps to try to help us achieve not having patients conglomerated together in one space. This reduces the likelihood of patients to have to use public transportation to attend appointments. And so that helps as well from a community standpoint of keeping patients out of the way of the public transportation system, and they can do this from the comfort of their home. This also enables clinicians to continue patient engagement while reducing the potential for exposure of patients that are, that might be the most vulnerable to COVID-19. So who would that be? Anybody that has chronic medical conditions, the elderly. There's reports that there's a 20% mortality rate for patients that are 80 and over. So if you have an opportunity to use telehealth in an older population, that's greatly impactful for them, and that decreases the risk for them developing COVID-19, whether that's from your office or even just transportation on the way there. Of course, you have limitations because telemedicine can be a little bit more difficult to navigate when we are using different platforms for the elderly, and so education needs to go behind that as well. This allows monitoring of patients and identifies potential and confirmed cases without person-to-person contact. And in an ED setting, we are really looking at that pretty aggressively. We want to make sure that if you're coming in and you're a patient that you have symptoms that are consistent with COVID-19 and you're a patient under investigation, I want to know that before I walk into the room. So if I have the opportunity to do a screening or an evaluation using telemedicine, and I'm remotely, I have to be in the next room and not near you and not breathing the same air, and do a screening exam, that will help me delineate if this is a patient that is a PUI, a patient under investigation, or not. And then I can appropriately triage them to the right area as well. So we've been starting to use that in an ER setting, and that's been very helpful. And really from a provider standpoint, this is a great opportunity. So if you are somebody that actually is a patient under investigation and you're a provider or you've had to be quarantined or isolated, this still gives you the opportunity to work. So if you have to be isolated away, you can still interact with patients and other colleagues using telemedicine. And that's really a profound, wonderful way to use telemedicine and still be able to have a job and a paycheck as well. So that's great. There's been a lot of federal policy changes, and we're going to go through some of those. And again, as I go through these slides, some of them are already outdated. I made these slides last week. One of them is already outdated, and then literally yesterday there was a new provision that came in, which I'll talk about as well. There's been a waiver of regulatory requirements related to HIPAA-compliant telehealth platforms. And so basically what you have to have typically, if you see on the bottom there, you have to have a business associate agreement with a HIPAA-compliant video communication vendor. And so what the government has been able to do is pretty much say you don't need to have that BAA in place, and you can use other common video chat type of platforms, such as Apple FaceTime or Facebook Messenger, Google Hangouts, or Skype. So there's all sorts of different venues that typically is not something that we're able to use on a normal basis because of the HIPAA compliancy issues. But now that's been somewhat, they're turning their face away from it, or they're not imposing any type of legislation, or should I say, not imposing any type of fines, and they're not investigating to make sure you're doing it correctly. Now, what they're doing is saying, listen, be aware of your surroundings. Use common sense. Obviously, don't use a public-facing remote communication. Do a non-public facing remote communication. Make sure that your patient is in a private environment. Make sure you're in a private environment where other people can't hear what's going on as well. But they're allowing these other platforms that typically aren't used in a HIPAA compliant situation. There's been some Medicare changes. Let me go to the next slide and I'll come back to this one. The DEA and SAMHSA have really been pretty aggressive about changing the buprenorphine requirements as well. So in light of the corona pandemic, the DEA and SAMHSA have gotten together and have authorized practitioners that can admit and treat new patients with opioid use disorder in this public health emergency. And we'll talk a little bit more about the specific rules behind buprenorphine versus methadone as well in an MAT situation. Patient location, usually a patient can't be at home to begin treatment. They usually have to have a face-to-face visit, or they have to be in a clinic, or it needs to be a rural situation. That's been also relaxed as well. So if you're in an urban environment, the patient's at home, the location of where the provider is not being looked at as much as well. So that's been relaxed. And so geographic location's been relaxed. And so really a patient could be in their home. You could be in your home. And you don't have to have these specific locations that are usually the rule when you're using telemedicine. So, and that's just during this COVID crisis as well. But who knows? Some of these changes may end up sticking long term, and we'll see how that goes. Eligible services, all services that are currently eligible under Medicare telehealth reimbursement policies are also included in this waiver. So Medicare allows beneficiaries to receive telehealth services within their homes, and CMS will not enforce an established relationship requirement. Telephones, typically with the audio-visual capabilities, can serve as adequate equipment for telehealth as well. And you see there's a link at the bottom. Several of these slides have links, and I'll give you quite a few resources at the end of this as well. Medicare changes during the COVID-19 have been pretty aggressive. Medicare beneficiaries will be able to receive a specific set of services, like typically a common office visit can now be done. Mental health counseling, preventive health screenings can also be done through telemedicine as well. And these visits are considered the same as in-person visits. They're paid at the same rate as regular in-person visits. And that's been a big, that's been one of the difficulties in the past of just making sure there's parity when we're talking about we should be getting paid the same amount for a telemedicine versus visit versus a inpatient or an in-person face-to-face visit as well. Medicare will also make payment for professional services to beneficiaries in all areas of the country. Again, it doesn't have to just be rural settings, and there's some states that say, listen, we'll allow telemedicine in areas that are difficult to access, but we're not going to allow that in an urban setting. Right now, that's being relaxed as well. Medicare makes payments for Medicare telehealth services furnished to beneficiaries in the healthcare facility and in their home. So again, location was something that was a big sticking point for Medicare reimbursement, whether the provider needed to be in a brick and mortar clinic situation or the patient did. There are certain specific details that had to be followed for that to be reimbursed correctly. Now it's much more relaxed. The patient can be in their home. The OIG is providing flexible being flexible for healthcare providers to reduce or even waive the cost sharing for telehealth visits paid by the federal healthcare programs. And Health and Human Services won't conduct audits to ensure that such a prior relationship existed for claims submitted during the public health emergency. Again, at times you could use telehealth as long as you could show that you had an existing relationship. That's been relaxed as well. An initial relationship can start via telemedicine. So that's a pretty big change as well. Other federal policy changes, again, who are the eligible providers that this actually affects? Well, it's almost everybody. I can't even think of another group here, but physicians, nurse practitioners, so all the mid-levels, nurse specialists, nurse midwives, psychologists, clinical social workers as well, dietitians. And so That's important that it really is allowed to be used on many professional levels. Licensing, there's requirements that physicians or other healthcare professionals hold licenses in the state in which they provide services. So if I have a license in Alabama, although I live in Florida, I can give services to a patient that's located in Alabama. And there's even been further relaxation from a state-to-state standpoint. For instance, Florida is allowing some providers that don't have a license in Florida that can get emergency privileges and provide services for patients that are in Florida as well. And we'll talk a little bit more about that. Specifically, in regards to opioid treatment programs, there's been other legislation that has helped us. This is not specifically telemedicine, but it's helped relax other issues that have allowed telemedicine to be a little bit more usable in a sense. So SAMHSA has made a blanket exception for those of you that work in methadone treatment or opioid treatment programs. You know, there's very specific rules about how patients get take home. They have to meet a certain amount of requirements, and then you have to make an exception if it goes against any of those rules. You have to make an exception to SAMHSA and get approval for take homes. Well, they've made blanket exceptions from SAMHSA, basically saying patients that are stable can get up to 28 days of take homes, and you don't have to go through the exception process. There's just a blanket exception. And then unstable patients can get up to 14 days. Now, you know, in reality, an unstable patient, just the thought of that, giving somebody 14 days of take home, you're allowed to kind of delineate as a provider who's stable, who's unstable. Ultimately, you could have a patient come in every day if needed. But what the whole purpose of that rule was is, what can we do to get patients to not have to come in and be together in a group situation as often as they usually are in an OTP setting. And so they've allowed providers and facilities to make those decisions on how often a patient needs to come here, and we don't have to go through these extra things for specific exceptions. There's a couple other provisions by the DEA. It's also allowed OTP staff, the opioid treatment staff, to deliver take-home medications to quarantine patients. So if you have a quarantine patient, they can actually have staff that go to the house and do drop-offs of the take-home medications. As a matter of fact, yesterday a new provision came out from the DEA that will allow for off-site locations to serve as a site for OTP staff to dispense take-home.
I apologize. It sounds like there's some sound coming from the background. If everyone can check their computer and make sure you're on mute while he's speaking, thank you.
And so basically the DEA said you can take, because when the OTP staff was delivering medication to patients' home, it was pretty overwhelming. There's just not enough staff to go around to do that. And so they're now allowing a separate site. So for instance, if I were to take, 20 patients take homes, I have 20 separate patients, I take the take homes to one location, and I were to dispense those take homes to the patients coming to the clinic. We would actually have to license that area as an OTP. They have to go through an OTP license, and now they're allowing that to be an off-site location where OTP staff can take the take-home medications. The patients can go to that off-site and receive those take-home medications, as opposed to having to go door-to-door and drop off as much. And so that's a lot more beneficial for the OTP staff. So SAMHSA and the OTPs, or new patients, are being admitted to an OTP. When we're going to be using methadone as the treatment of choice, then they still have to have a face-to-face evaluation. So we're not allowed to use telemedicine on an initial visit if we're going to be using methadone. That is different if they're going to be using buprenorphine. So buprenorphine now, you don't have to have a face-to-face evaluation in an OTP. And as a matter of fact, if you look at the bottom statement, the DEA had not made a determination about using a telephone. Could a telephone be used as an initial evaluation? Last week, they finally came out with a ruling. The DEA says that OTPs and the Data 2000 providers can treat new patients with buprenorphine based solely on a telephone call. So the DEA has allowed telemedicine for new patients, but now will allow telephone during the COVID crisis. So there's no change in the history. I mean, you still have to get the history from the patient. You just have a limited physical exam. I mean, basically, you're talking to a patient, and you can tell if the patient is sedated or not. So I think the intention, obviously, is to make sure that patients are not going without their MAT. And I think the really important take home here is just to make sure you document. It's very important that you say whether I did a telemedicine evaluation, I did a video evaluation, or I did a telephone evaluation on the patient. That'll be important to at least document that as well. Practitioners that are working in OTPs can continue treating existing patients with methadone and buprenorphine via telehealth. So if you have an established patient that's on methadone, you can use telemedicine in that regard. And an OTP can dispense medication based on telehealth evaluations. So you can still dispense that and make medical determinations. It's just that face-to-face evaluation for the first visit, if you're going to use methadone, is still in effect. That's something we've been writing letters to Dr. McCann-Kantz and trying to get some movement in that regard. But so far, there's not been any changes. Flexibility for prescribing. The DEA registered practitioners, they can issue prescription for controlled substances to patients, excuse me, who they have not conducted an in-person medical evaluation. So again, we're talking about a controlled substance, not buprenorphine necessarily. The prescription, of course, has to be used for legitimate medical purposes. Practitioner acting in the usual course in the professional practice. If this is something that they don't usually do, they shouldn't do that. The telemedicine communication has to be an audio-visual, real-time, two-way interactive communication system. It needs to be acting in accordance with federal and state laws as well. Practitioner may issue a prescription either electronically or by calling in an emergency Schedule 2. So typically electronically, you'll have to do Schedule 2 through 5, but you could also call in a Schedule 2 prescription to the pharmacy, and you can call in Schedule 3 and through 5 prescriptions as well. If a practitioner has that Data 2000 waiver, they may prescribe buprenorphine under the Data 2000 waiver, but you still just remember that that patient will still account against the practitioner's patient limit as well. There's been some relaxation in regards to the 42 CFR, typically trying to get patient consent. So providers may not be able to obtain written patient consent for disclosure of substance use disorder records. But we also need to remember that, if you're going to be giving out information, you've got to make sure this was a bona fide medical emergency. The patient's prior informed consent can't be obtained in that situation necessarily. And so it's been relaxed from that standpoint during this crisis. So specifically to the state of Florida, again, for ACA and Medicaid, you don't need to have federal approval for the following stuff. So this is going to cover physicians and physician extenders, advanced APRNs and clinic providers as well. The Medicaid is going to cover medical services that will also include evaluation, diagnostic, and treatment recommendations. It covers behavioral health evaluations and treatment as well, and it reimburses services using telemedicine at the same rate. And that's a very important thing because oftentimes there's been, again, a non-parity situation where we're not getting the same rate. It's important that you make sure you're using the GT modifier for the procedure code and the fee-for-service delivery system. Many of the commercial insurance carriers have also followed suit by allowing telemedicine and telehealth services to be paid at the same rate as an in-person, and they've expanded those allowable services as well. But it's important, as I was doing research on this, you can go down quite a few rabbit holes, but you're able to find quite a few codes and new codes that are available in individual insurance carriers, and it'd just be important to check with them as well, what they will and will not cover. So other state of Florida policy changes, the telehealth requirements to ensure treatment services are medically necessary and perform. It needs to comply with HIPAA regulations, but again, that's been relaxed. So the Office of Civil Rights are not going to impose penalties as long as you're using a good faith use of telehealth. So again, they're not imposing penalties. They're not looking for people that are being egregious. They're trusting us to do the right thing in that situation. Supervision requirements with mid-levels within the provider's scope of practice, that continues to apply. That doesn't change. Again, they want you to make sure that you're documenting regarding the use of telehealth. So using that documentation, saying that you're using telemedicine, what type of telemedicine you're using, and putting that in the medical record or the progress notes as well. If you're going to see minors, you still need to have the parent or the guardian there during the duration of the service providing that use of the telehealth. And again, like I had mentioned before, some states do this and some don't. Florida has allowed the out-of-state practitioners who are not licensed in Florida, they can provide telemedicine services to Florida Medicaid recipients, but they got to go through a provisional enrollment process. It's a little bit arduous, but after they get through that, they're able to provide those services to our Medicaid patients. All right, so that was a lot of legislative stuff. Some has been changing as we've probably been talking. And so I would just continue to use some of the resources that were provided on the last slides here, and you will be able to find a little bit more information out in regards to the details of how the DEA or CMS has started changing some of the ways that they're seeing telehealth and allowing. So how do you implement telehealth? And that's, this is an individualized type of decision for each clinic, each provider. There's lots of vendors out there. One of the first places you might want to check is whatever EHR you're using, see if they have telemedicine that's already integrated within their system. And I think that's important to at least ask them first. They may be all set up, ready to go, and you can just turn that functionality on, and now you have it integrated with your own EHR that already exists. Regardless of whatever EHR you decide, it is very important to practice using it first before you start seeing patients. So I've been using telemedicine on different venues, whether it's the ER, in an OBOT, in an OTP, or even internationally. Each time I've had to use different types of services. I've used Wi-Fi, I've used 4G, 5G, 3G, hotspots, every way you could think possible. But it's important to try different types of technology, and maybe even have a backup technology if one of them doesn't work. So whatever application you decide to use, practice with your staff before you use it with the patient. And then also establish those protocols in case something doesn't work, right? So suddenly we don't have audio. Can I pick up the phone and use my phone and also use a computer at the same time because I don't have audio? So try to think outside the box. There's lots of different ways that we can communicate and talk with patients. Check with your malpractice insurance carrier. So that's important. If you're not covered for telemedicine, that might be a little area that you have a little gray area. So you don't want to put yourself up for possible issues that you weren't covered seeing a patient. So if you call up your insurance carrier, most of them do have provisions to provide telemedicine as well. Sometimes state licensures, it depends on the state, will change trying to get recertified in the state for licensing. And so you may want to check for just specific state requirements as well. Again, we don't really endorse any type of vendor that's out there, but again, you can use some of the common vendors that typically may not be used, like FaceTime. Again, if it's not HIPAA compliant necessarily, and so you can't use just FaceTime because there's a concern about HIPAA, but again, it's relaxed right now, so you can use things like WebEx and GoToMeetings and VC or Amazon Chime or Google Hangouts or DoxyMe, UpDocs. There's all sorts of things out there, and you can probably Google that and find tons of those options as well. It may even be worth having a couple of different venues. I've used something called SWIMED, and then the next patient I saw on Zoom. So, having different applications can also give you the ability to reach more patients that may or may not have specific access to certain platforms. And so just having a little ability to think outside the box and be willing to use different platforms can be very helpful as well. no matter what, it's important to communicate those changes with your patients. Some patients are going to feel uncomfortable. They're going to feel like it's impersonal. But, talk to the patients, especially during this COVID-19 outbreak. Our goal here is not to have patients together. We're trying to limit the contact of people. And so, explain to them that this is what we're trying to do, and this is the reason we're trying to do it as well. Post that information on your website, call patients up before their appointments, offer those telehealth visits as opposed to inpatient visits. You'll be surprised a lot of them really do want to do that, and people are taking this situation quite seriously and doing the right thing and not trying to get out and about. Think about your workflow. You're going to need to determine when telehealth visits will be available on the schedule. For instance, you can block a time out saying these are my times that I'll see telehealth patients, and this is the time that I'll see inpatients, in face-to-face patients. You, as a provider, I've found it very freeing to have a little bit more flexibility in my schedule. Or let's say you have a patient that just inadvertently shows up late and you're already driving home. I can pull over on the side of the road and I can see that patient on my telephone. And so it's opened up opportunities to see patients when maybe some inadvertent thing had happened, they couldn't come to the appointment. And so that's helped quite a bit too. Remember documentation, keep really good records. I would encourage you to document that how you're seeing that patient. I'm seeing them through the telephone. I guess you're not seeing them, but you could be. It's just telephonic. But if you have video capability through the telephone, document that's how you saw the patient and what extent of an exam or that you did or couldn't do as well. Checking in with patients, determine where those trouble areas are for them to make those changes. Did they struggle with this type of communication? Again, with the elderly, we may actually have to do a little bit more training, just how to turn types of technology on. Just like during this webinar, I didn't know I had to move my cursor around a little bit just to change the slide. So we had that communication. You learn kind of on the fly sometimes. Start with a really good quality webcam if possible. Most of the phones now are pretty impressive. You have really good video capability. But again, it can skip. There can be delays, and understand that if there are delays, give a couple of seconds of pause before you start talking to see if the other person is going to talk as well. We'll see that on quite a bit of video conferencing applications. But whatever you decide to use, make sure you're practicing it, troubleshoot it. Always have that backup plan. That's always important as well. Some real, practical things to think about is, set the webcam up at eye level. If you have your phone, try to put it up in front of your face like you're talking to a person, and you want to look at the camera. You don't want to look at the screen, and that can be very difficult because if you're looking away at the camera, that's not necessarily, if you're looking at the screen, that's not necessarily looking at the patient. If you're looking at the camera, you're seeing the patient directly, and that makes it look like you're looking directly at the patient. That feels better for the patient as well. Keeping it at eye level is important. If you have it down below down by your chest and your phone is looking up at you, you're looking at your nose and seeing if there's bats in the cave and stuff like that. You don't want that. That's kind of gross, right? So you want to have it face to face. You're looking at each other and it's more personal. Really, it's important to remember what's behind you, right? So professional space, dressing professionally, they can see you. They can see what you're wearing, at least from, the chest up. But be cognizant of what your surroundings are, making sure that you're in a private area, a quiet area. Turn off other sounds. Let other people know in the house here, if you're at home, that hey, I'm going to be on the computer. I'm going to be doing telemedicine, so we're not getting interruptions. Turn your ringer off. That's important as well. Engage. Also have proper lighting. If you're sitting and you have light behind you and you're just dark, that's not a good situation as well. And again, know your surroundings. You don't want to be sitting here seeing a patient in your bedroom and then suddenly your spouse comes out of the shower and didn't know you were on the telemedicine, and that could be a very embarrassing situation and could dramatically change your relationship. So you don't want to do that either. So engage your patient, maintain eye contact by looking at that camera. If you're going to be looking away at the camera, let's say you're using your EHR, you're going to be looking at notes, tell the patient, I'm going to look away from the screen, I'm just looking at notes. Tell them what you're doing because they can't see what you're doing necessarily. They can just see your head. So use head motions like nodding or shaking your head. And especially when the patient's talking. You're giving those nonverbal cues back to the patient, just like you're there in face-to-face time as well. Lag time, remember, there's a little bit of lag sometimes when you're using telemedicine, so you can often talk over each other. So give a little important pause there just to make sure that you're not going to talk on each other. And then obviously avoid having interruptions, as I'd mentioned before. Specifically to OTPs, when we're talking about treating quarantine patients, and I've mentioned some of this before, they've also allowed, and I just added this here at the end, just some other things to think about, especially if you're in a methadone clinic. They're allowing identified, trustworthy, patient-designated, uninfected third parties. So a family member, a neighbor, that can actually pick up the medications from the OTP and deliver that to the patient's home. And so they've allowed for that to happen as well. And if that trustworthy third party is not available, they've also allowed doorstep delivery. And as I'd mentioned before, they've also allowed off-site locations to be used to dispense take-homes to established patients as well. No matter what, the medication needs to be in an approved lockbox. You need to communicate with the patient prior to delivery to reduce the risk of diversion. So making sure there's good communication. You're not going to just drop it off at the door and now maybe a child or a pet gets into it. That'd be a very bad situation. And with that relaxed legislation and relaxed exception policy from SAMHSA, obviously a lot more take-homes are going out. Need to be thinking about protection with naloxone kits, get it to family and friends, make sure that there's naloxone being given or at least prescriptions for naloxone, letting them understand that they're going to be having more medication than normal, and so we want to make sure that they're not going to have an overdose situation. All right, I went through a whole bunch of stuff there. We have a lot of resources at the end, and I'm happy to take any questions. Hopefully I can answer some of them, but go for it.
Dr. Stavros, we had a attendee ask, so does Medicare allow licensed mental health counselors to provide services?
And yeah, I believe the answer is yes to that. They're allowing that as well. And I can go back to that slide if it makes a difference. So I just have a list of all the eligible providers, but just to be specific, I would definitely go to CMS and make sure that that specific group is covered. Again, it's changing rapidly, but if you go to that link at the bottom, hopefully that will share some of that information.
There's another question on the board. What if clients are dropped from internet or internet goes down, which is happening a lot? Medicaid will only bill for audio and video telehealth, not telephone. So often they miss their therapy. Can telephone therapy be considered?
Again, I can't speak for if it's going to be covered or not. You've got to have a backup plan no matter what. So if you are losing video coverage, audio coverage, again, I would try everything possible to make sure you have another way to communicate if possible. If the only way you can do it is telephone, I think you should document that very well and see if they'll accept it. I don't know if they will or not, though.
Are there any resources for telehealth for deaf patients?
Ooh, good question. So I know, and I don't know that answer specifically. I would assume it does exist in our emergency department. We have language capabilities. So if somebody doesn't speak Cantonese Chinese or doesn't speak sign language, and we have a patient that's deaf and we need to communicate, we actually go through this language program where it's basically using an iPad and they're able to interpret what's going on in that situation. So I suppose there probably is some capability for that. I just don't know much about that specifically.
Are you able to repeat the policy about take-home delivery?
For methadone, is that?
I think so, yes. Yeah,
so again, there's a blanket exception. I don't know if that's what they're looking for, but there's a blanket exception from SAMHSA saying take homes for stable patients, and that is up to the clinic and the provider to decide who's stable. You can have a blanket exception for 28 days of take home. And these are for patients that obviously are on methadone and have opioid use disorder. And you can also have 14 days of take home for patients that are, they say unstable, but less stable. But the OTP believes that they can safely handle this level of take home medication. And again, they leave that up to the provider and the clinic to decide who can handle that medication and who cannot. A lot of clinics I know have gone to an every other day dosing. So for patients, for instance, if you're a new patient, you're going to come every day. I mean, that's the right thing to do. We're not saying, hey, you're a new patient, here's 14 days of take home. That's not going to happen. You're still going to come every day. But what we're trying to do is limit the patients that have obviously shown that they're going in the right direction and allow them for more take home. So instead of having to come every day, maybe they're coming every other day. Maybe they're coming 2 times a week, or maybe even 1 time a week. And so instead of going through the whole exception process, they've done a blanket exception from SAMHSA, so you don't need to request that. You can make that determination from a clinic standpoint. In regards to take homes, again, if you have a responsible third party that can actually help deliver those medications, maybe a family member, again, you have to make sure that this is somebody that's not in question, but an uninfected person that can come to the clinic and take those medicines to that patient, making sure that you're documenting that and making sure that you have good communication with the patient as well, so there's a decreased risk of diversion to that situation. Again, take homes can be delivered to patients. Again, having enough staff from an OTP standpoint is part of the barrier. So they've also just allowed an off-site location to be developed. So if I wanted to go to another location outside of my OTP and I'm bringing take homes for patients that happen to live in that area that are further away from the clinic than normal, the patients can go to that location and pick up the take home. So that's an off-site distribution of take-home medications of established patients. Typically, you need to have a license as an OTP of that off-site location, but right now they've relaxed that, so you don't need that. So I hope that answered that.
Okay, we have another question. For an outpatient MAT program utilizing telehealth, is a UDS still recommended and suggested on how, or any suggestions on how to get this done in a tele environment?
Yeah, that's a great question. Again, I think everybody's trying to figure that one out too. So, you obviously have off-site locations. They can go to different labs to get this done as well. I think some places have just made determinations on deciding how often urine drug screens need to be done. They may be relaxing that a little bit. Again, I haven't seen, and maybe somebody else knows this online, but I haven't seen any specific guidelines into regards to how often it needs to be done. Has that been relaxed? And so I don't know specifically if that's changed at all. Again, it's been left up to the providers to try to make a determination of who's stable, who's unstable, who needs to have more urine drug screens. And then there's, the big talk about how beneficial is it in the first place. So you're going to get those talks as well. So it's opening up more discussion. I think that's going to continue to have more discussion. And this could be an interesting time where we are probably going to have studies come from this situation where, hey, look, I have this group of patients that I wasn't able to do urine drug screens on, and this is what happened. Were they more stable, more unstable? Was there any change? And I think that'll be interesting to see kind of what the fallout is from that. Not fallout, but what kind of information we can glean from this situation, because we're forced in a forced in an environment where we need to make changes and maybe not enforce some of the things that we've done before in the past. Are those rules and regulations that we've enforced even beneficial? And I think that might even change the way that we look at it and at least question why we do it and if it's beneficial. All right, long answer for.
Thank you. And what would you say?
I didn't even answer the question, did I?
Thank you. What would you say is the average length of telehealth sessions, and are they as effective as face-to-face?
It totally depends. Again, on new patients, I think that there's probably not a huge difference on visit time. for my stable patients, I know it can be very quick. But again, a lot of stuff kind of happens behind the scenes. So again, if I have a patient that comes into my OBOT, they're seeing a counselor, they're seeing my office staff, they're maybe getting a urine drug screen, maybe they're filling out paperwork, and by the time it gets to me, I've been given a synopsis of what's going on with that patient. I can access my EMR if I need to, and then I can have that conversation with the patient. And you can determine how long it needs to be basically on how the patient wants to spend the time. If they have extra questions, you can take the time to do that. So again, you can do it any way you want to, but I haven't noticed that there's been really a huge change one way or the other from a timing standpoint.
Thank you. What are the best practices for meeting with suicidal clients or potential situations for Baker Act?
Ooh, that's a good one. Yeah, I don't think there'd be a change. If you have a fear that the person is suicidal, you've done an assessment, whether that's telemedicine or not, obviously if you feel the person's at risk, then getting law enforcement, I think, is going to be very important in that situation. So again, documenting, if you have a situation that you think the patient, if you anticipate you may have an issue, finding out where that patient is located is going to be important too, probably early on in the conversation. Not later when you're trying to figure out where this person is and trying to get law enforcement. So, but yeah, that's a good question. So I don't think it changes much. You still got to have law enforcement involvement at that point.
And we have another question. Would I be able to open a private practice from my home address and begin accepting new clients via telehealth?
I guess that kind of depends on what the private practice is. If you're going to be, let's say you have an established practice. So let me just give an example. If I wanted to start seeing patients from my home using telemedicine and I just want to expand my OBOT services, right now I can do that. I can literally just do that by telephone. Now, figuring out how you get paid, that's a little bit more difficult, right? So you're going to have to figure out, well, if I'm going to do this, how do I bill the patient? How do I get their insurance information? So there's a lot of stuff that goes behind that from a business standpoint, you've got to figure out before you do that. So, but again, when you're talking about just what's been relaxed, you can see patients from your home, and that's been relaxed on some accounts. You don't have to be in a specific location. The patient doesn't need to be in a location. But creating that business model is probably the hardest part of trying to figure out how do you get reimbursed adequately and setting up that business first. So.
Thank you. Had a couple other questions. How valid are telehealth SUD evaluations that refer a client to SUD treatment, talking about therapy, that are involved in the criminal system, and what are the legal liabilities for defense attorneys to that mandatory referral for treatment? Is it a video link, or is a video link necessary?
That's a good question. So how valid is a substance use disorder evaluation? Is that the question?
Yes.
I don't know how to answer that one exactly.
And we can check into that and answer. Yeah. There's also a couple of comments that Zoom allows users to create third-party agreements. And also Doxy.me is HIPAA compliant to use.
Yeah, Doxy.me has been used prior to all this. It does have HIPAA compliance. You can check to see which ones are and which ones aren't. Just for right now, during the COVID crisis, they are allowing pretty much anything. So.
And we had another comment that TransPerfect Connect is also has the ability for translators for individuals who have limited English proficiency or hearing impaired.
There you go. All right. Well, good.
I'm an LMHC in the child welfare industry. My agency is new to telehealth. My dilemma is not all my clients are appropriate for telehealth. such as trust issues or a slow learner. So how do I engage this client?
Yeah, again, not every single person is going to be perfect for telehealth. I mean, basically, what's happening now during this crisis, they're just relaxing the regulations and allowing people to use it more often. But again, it is not necessarily perfect for everyone, and there's still going to be those situations where an in-person visit is going to be the best visit as well. Again, just like when SAMHSA says, hey, you can give 14 days of take-home to unstable patients. Well, most providers are not going to say, oh, that goes for everybody. No, they're going to individualize who can and be able to do that and who's not able to do that. And you have to make that determination as a provider standpoint. So if you have somebody, and going back to that last question, if you think is suicidal, you may have to have, more close contact with that person, or somebody's developmentally delayed or elderly and they just can't figure out how to use the technology. You may actually have to continue doing the same old treatment of seeing them in person. So you just have to individualize that.
And how do you know if a platform is HIPAA compliant?
I would just go to that specific website. So for instance, doxy.me, if you go to their website, they will tell you if they're HIPAA compliant or not. You could probably Google that. I think that's really important information to know. But right now, during the COVID time, you can pretty much use anything, even FaceTime. You just need to make sure that it's not something that other people can access. You could imagine if we just assumed, is Zoom HIPAA compliant or not? Well, people are bombing Zoom and you can get access to that account and get into your meetings, and that's probably not HIPAA compliant. So, there's some pretty safe assumptions out there that FaceTime and Zoom are probably not HIPAA compliant. But if you need to know specifically, I would just go to those websites and find out.
Can mental health targeted case managers see clients via telehealth?
Say that question again.
Can mental health targeted case managers see clients via telehealth?
Not sure. I'm not sure, and I don't know how are you billing for that, I think is the question. Who's paying for that service, and then whoever's paying for that, whether that's Medicaid, Medicare, I would go to that agency or the CMS and make sure that's listed as a covered entity under telehealth.
Okay, thank you. And what about Vivitrol patients? What is the process?
Again, that's right now, even before the COVID crisis, you could see those patients via telehealth. Again, it's not a controlled substance, and that's where the rub is. So we're talking medication-assisted treatment with controlled substances. You need to have that in-person visit typically. But with Vivitrol, since it's not controlled, you could establish a patient relationship via telemedicine and actually prescribe that medication. If you're set up right, you could even have a nurse administer that medication if you're not on site. And so that's even prior to COVID, you're able to do that too.
And let's see, do you have any coping with stay-at-home resource suggestions for patients with children?
Coping resources for staying at home and having to spend more time with your kids, is that it? No. I don't. I just know you got to have a lot of extra patience. So I don't have any resources. Maybe y'all have some there at FADA. I'm not sure.
Yeah, we do have a website with resources on our COVID-19 webpage. We have a couple more minutes left. If you have any other questions, please send them. Is Medicaid losing the requirement to be seen weekly in a clinic with takeouts being extended?
Takeouts for what exactly?
I'm not sure. I apologize. We can try to respond to that one later.
Okay. And I think I saw a comment that somebody wrote in there that Blue Jeans, which is also another telehealth platform or a video conferencing platform is also HIPAA compliant. I'm not sure. I just saw a comment that somebody said that it is HIPAA compliant.
We had another question. Any advice on urine drug testing during these times?
Yeah, again, it's just, I think we're all trying to work through that. For your more stable patients, you're probably going to be able to relax that a little bit more. For more of your unstable patients, you're just going to have to make that determination if it's beneficial or not. I haven't seen any specific legislation one way or the other, and that was a big question that came up with another teleconference last week, trying to determine what makes the most sense with urine drug screens. Again, I think we're going to learn a lot from this time and the lack of ability to do urine drug screens in some patients, and how did it affect them? Did it make it worse or better? Or how beneficial is, checking a urine drug screen every week or every month or every 3 months? How does that impact patients' stability and virtual outcome? Or eventual outcome. I think that'll be interesting to see what kind of comes out of that.
Okay, so we have time for a couple more questions. How does this affect billing? For instance, my sessions typically last 50 minutes to an hour based on insurance, but some platforms are only allowing 40 minutes limited free meetings. It seems we'll be losing pay.
Yeah, and again, you're going to have to look at it at your, if you're talking about like something like Zoom, I think the free version of Zoom only allows 40 minutes, but there's other platforms out there that don't determine length of time. So you may want to look at all those other opportunities that are out there for you to use that will extend that time. If you feel like you need to get to the 50 or 60-minute mark for patients, that'll be something to look at. And find out how much, if you have to use Zoom or one of the other ones that say you need to pay for it, you may have to at least think about what the cost is and how much money that could save you by subscribing to that and then being able to bill appropriately.
Okay. And also, are employers required to pay for platforms if there's a fee for use?
I think that will totally depend on your employer, but I don't think they're going to force employers to use specific platforms or pay for certain things. So.
Okay. Did you see any other questions, Dr. Stavros?
I don't think I did.
Okay. Well, I know there's still a lot of questions out there, and we are taking a log of those questions so that we can answer them at a later time. So if we did not get to you, you'll hear back from us on the answers for those questions, or maybe another webinar or something to answer those questions. Well, Dr.
Right.
Stavros, we just want to thank you for your time today. We know your schedule's really busy, and you really touched base on a really relevant topic for us. So we thank you again for your time today.
Yeah, my pleasure. I just one real quick one thing. I saw somebody from Operation PAR from a methadone clinic. They're actually using oral swabs. I think that's another way you could do that. If you're not able to do the urine drug screens, you could do oral swabs for your drug screens. And I think that's another way to think outside the box. It's a little bit more costly, but for those patients that you really, really need to have that result, that's another way to do it too. So, but thank you everyone for letting me share this with you. Hopefully I answered questions and didn't create more, but again, it is a fluid motion. Things are changing very rapidly, so really try to use the resources. We do have quite a few at the end of this webinar. Feel free to utilize those. There's a lot of information out there.
And thank you again, Dr. Stavros. And if everyone could please stand by, we have some housekeeping slides that we need to go through with you. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger@WebEx. The evaluation will close at midnight on Friday, April the 10th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. And again, we want to thank you for participating in today's webinar. We had a great response. We'd also like to recognize and thank especially the Florida Department of Children's and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold on for the evaluation. Thank you.